this is actually taken out of a Lancet journal, and that is a cartoon drawing cutaway of Ebola, kind of an elegant, very small structure, but interestingly, very pathologic, so very severe disease. And so these are the objectives that we sort of had set out. And basically, I think this is the most important one, to give you a solid but basic understanding in Ebola. All right, so I'm going to try and talk a little bit in the medical language and try and translate as I do that, because I think it's important for you to understand some of those words that you hear when and Sanjay Gupta or whoever gets paid for CNN or Fox News, whatever, is going to be talking to you about this stuff, so you can understand that a little bit too. So in general, Ebola is classified with a bunch of other viruses under the umbrella phrase a viral hemorrhagic fever. You probably have heard of some of these other viruses that fit under the same category, like hantavirus or Lassa fever or dengue fever. However, instead of calling Ebola hemorrhagic fever, we now prefer to call it Ebola virus disease, and I'll talk about why that is in a little bit. It comes from, when we classify viruses, we can go on down to the genus and species, but just above that is the family, and it belongs in the family of Filoviridae. And what that really means is it really talks more about its structure. It's a very small filamentous structure, which is why it has that Filoviridae, and it's related. The other genus is Marburg virus, which shares a very similar structure. And we'll talk a little bit more about that as well. It's an RNA virus. You don't really need to know that or remember that. But there are 5 species of Ebola that we should talk about. All right. The first one that you probably heard about in the news is the Zaire species. It has the highest case fatality rate. Thought to be close to 90% before this latest outbreak. It's somewhere along the lines of 55 to 88% case fatality. Originally found in Zaire in 1976. So the Sudan virus, the next most deadly, about a 50% case fatality. Ivory Coast species, there's only been 1 reported case of that, and that person lived. So arguably the least pathologic, the least deadly of the species. But then again, we only know of 1 person, so we don't really know how accurate that is. The Bundia bugio species, a 30% case fatality. And also a popular one is the Reston species. This was made popular by that book, The Hot Zone. I don't know if anybody read that book. I actually haven't read it, but it's a pretty good book, and so I hear. And it is about the Reston virus, or Ebola virus, which infects other non-human primates. And the book goes about talking about how this could be a potential threat to humans. And in 2008, they found in the Philippines, they found some pigs that were actually infected and died of Ebola Reston. And the pig farmers there actually were infected, were thought to be infected because if you measure their blood, they had antibodies against the Reston virus. And so, but they were never sick. And so that's maybe a potential for research there and in the future. So let's talk a little bit about what was in the news all this summer, which is the 2014 West Africa outbreak. It actually started in December 2013. We think the index patient, index being the first patient that we think had the disease, was a 2-year-old boy who passed away. And in the culture there, when they bury people, they do a lot of washings with that, which actually, as we'll talk about, is a good way to get Ebola, is if you're around a person who's infected and you're around their body fluids. It is, like I mentioned, the Zaire species of Ebola. And this graphic here, really the thing that I know it's kind of tiny in there, but this is West Africa sort of blown up. And the key point with this is the darker red areas are the higher concentrations of Ebola. And that is updated from this the World Health Organization as of January 7th, so pretty recent. And while you've noticed we've not been talking about Ebola, the media has not been talking about Ebola quite as much, it's still out there. There are less cases right now, and that's good, but also we have a lot of drug trials going on right now, and unfortunately, with the cases going down, people are really rushing to try and get their studies done with this. And so a total of almost 21,000 cases, and that's probably on the low side, with at least close to 8,500 deaths. So big problem. You may have heard, or may not have heard, that there was a second Ebola outbreak this summer in the DRC. So in the Congo, the Democratic Republic of the Congo, in a pretty remote area, no paved roads going in there. In August 2014, there was an outbreak of Ebola. An index patient was probably, is thought to be a woman who was cooking up some bushmeat. It was monkey. Her husband had found a dead monkey. They eat monkey there. He brought it home. She started cooking it. She was the first one to get ill. There were only about 66 cases. Well, you know, 66 sounds a whole lot lower than 21,000, but you can see the case fatality rate was pretty high, so 49, and it's probably isolated partly because this outbreak is geographically isolated from the whole rest of the DRC. There are no roads to get in there. You have to take either a motorcycle over through the jungle or a boat to get there. Whereas the West African outbreak was pretty cosmopolitan. So it was happening in a city where people had lots of contact with each other, and so it was more easily spread. This was also the Zaire species, but when we look at the genetics of the two species, you can think of it as a subspecies. It's a distinct outbreak. It's not related to the West African outbreak. So how do we get Ebola? So if I contract Ebola, I get sick and I die, but what happens, where does Ebola go? It has to have a reservoir somewhere. It needs to live in another animal that it doesn't kill. And so we don't know what the reservoir is for Ebola. We do know that bats are a reservoir for Marburg, which again is in the same family, right? It's very similar to Ebola. There is evidence that bats have been implicated as the reservoir. When we test bats in Ebola epidemic areas, certain bats, they actually have either antibodies against Ebola, which means they were probably infected with it, or we can find RNA genetic material, but we haven't found the whole virus in a bat. And so it's kind of, you know, circumstantial evidence, but it's really leaning towards like bats are the reservoir. Let's see. And also, what we do know is there are no arthropod vectors. That means that mosquitoes can't transmit the virus, and it's not transmitted that way. And so, if you come in, or if I get Ebola, how am I going to present? You know, we have this fear, especially if you've read The Hot Zone, a pretty graphic, you know, a picture in your mind's eye about what, you know, how am I going to feel? What am I going to present to the doctor? Like, you know, am I going to be bleeding out of my eyes, the ears, and is it going to be this horrible death? And that can happen, but two things are really clear that have been clarified with this massive outbreak that we've had over this last year. And one of which is that hemorrhage is much, much less common than originally thought. Maybe 20% of people who end up with Ebola actually have hemorrhaging. And what they do have, the second point is vomiting and diarrhea is a much more common symptoms. So, and the complications of massive vomiting and diarrhea can still, are life-threatening, can be life-threatening. Some facts here, and this will help dispel, you know, a couple things maybe. The incubation period, on average, is 6 to 12 days after exposure. So that means that after you've been exposed to Ebola, on average, it will take you about 6 to 12 days before you start to have symptoms, all right? The range for that is that's just the average. The range is anywhere from 2 to 21 days, and that's why we keep people, say, if I go to, you know, Sierra Leone and I'm treating Ebola patients, I feel fine, I come back to the United States, I should monitor my temperature or myself for any symptoms for 21 days, because that's as far out as we've seen people become symptomatic. And the other thing is, asymptomatic patients in this phase, so if I go to the bowling alley, like this doctor did in New York, but I don't have a fever, even though I've been treating patients, I'm not infectious. That's pretty clear. Once I have a fever, which can be the first sign, then I'm infectious and I need to self-quarantine. So this may be a little bit, didn't project quite as big as I had hoped, but this is a good way to think about what's going to happen to you if you get Ebola. So you're going to have this early febrile stage. That means you're going to have a fever, usually in you know, day 0, the day you contact somebody, to about day 3. You might have fever, malaise, fatigue, so you're feeling achy all over, you've got some body aches. You could have a cold. I mean, it's really non-specific. And that's why, as Connie will talk about, one of the important things for us to do with screening, since we have a large college population here too, and they're in dorms, colds, influenza, that stuff passes pretty rapidly through there. But we also have college students who have been to either from West Africa, or they're you know, may have traveled over there for research. We need to ask these questions about travel. And then the more symptomatic phase is a gastrointestinal phase. And so between days 3 and 10, you're going to end up with a diffuse, so abdominal pain all over, vomiting, diarrhea. You're still going to feel achy all over. You might have some red eyes, you might have some chest pain, your joints might hurt, you might have hiccups. You might be so dehydrated that you might have an altered mental status. You might, you know, be sort of out of it with your, with regard to your mental status. So, and then the break point is about day 7 to 12. Either people tend to get better after this, or they tend to get worse, right? And if they get worse, usually it's from, it's shock, so your blood pressure drops, your heart rate goes up, you might have really bad, really time breathing, you might need to be on a ventilator, you might need other intensive supportive care. And this is where, if you're really sick with that in the United States, even in Pullman, we've got an ICU. We can do a really good job of supporting somebody. Maybe not, we wouldn't keep that Ebola patient here, and we'll talk about that. But just in general, a sick patient like that could literally be resuscitated in a lot of small towns in the United States. In a resource-limited area like Sierra Leone, you're talking about giving oral fluids to somebody who's throwing up. It's very, very poor, and so the mortality can be quite high with that. And then late complications, that gets into the people who are really sick, who come to the intensive care unit, and we do the things that we do in medicine, which a lot of times is pretty invasive. We put people on ventilators, we put big IVs in people. You can get infected from either of those routes. So treating a secondary complication, so a pneumonia that you got because maybe you were on the ventilator, or you become septic from an IV that's been in, all these sorts of things. It can happen. So, and this, I thought this was interesting. So this is a flyer that and a sign that the CDC had posted a while back. And if you just if you black out the Ebola part, all these symptoms could be the flu. I mean, and so that just, to me, drives home the point in that you really need to take we need to, as providers, need to take a clear history on where you've been. So, which is becoming harder and harder every day in the United States. Yeah, emergency departments are busy, they're packed, you know, so providers are trying to do their best and be as efficient as they can, but it's a reminder to us all to take the time to ask those questions and do things right. And so, and what's your doctor going to find? So if a doctor looks at, you know, we take your blood and we send it off, that's important for us to know how, you know, how dehydrated are you with this vomiting and the diarrhea. They're going to see a low white blood cell count, you know, and this is just for your general edification. Your platelets are going to be low. Now your platelets are involved with clotting, right? And so if your platelets are low and you lose your coagulation factors, also involved in clotting, that's where you start to get bleeding. Now these kind of findings are not unique to Ebola. We see this with a lot of different diseases. So the potential for you to have that when you're really sick in general is there. But probably the most important is electrolyte abnormalities. Vomiting, diarrhea, you're going to lose sodium, you're going to lose potassium, your calcium can go down, magnesium levels. So aggressive fluids and also electrolyte replacement is important for us as providers. And so how do we diagnose this? It's really non-specific, and again, we have to have a high index of suspicion. So what we're going to be, we need to, as providers, we really need to think about it first. Is it possible that you could have Ebola? Because if I don't think about that, I'm never going to make the diagnosis. Have you been to an epidemic area? West Africa, Central Africa are the sort of the hot spots. I'll say there was a Marburg case in Uganda this summer as well. Also equally scary as far as these sorts of things. And so while we ask the questions, have you been to West Africa or Central Africa, the question should also be, have you been outside of the United States? So it's a more general, because Ebola has been in other places as well, and there's Marburg out there as well. And then we need to rule out common things that give you these symptoms, like influenza, and if you have been overseas, malaria, typhoid fever, and influenza are much more common than Ebola. And then once we've taken this history, the CDC actually has us risk stratify patients based on where you've been, who you've been in contact with, do you have a fever, what symptoms, what symptoms do you have? And they classify it as, are you high risk, sort of a moderate risk, low risk, or no risk? And what we do and how we test you is based on their recommendations. And we will send serum tests. So we'll send a blood test. If you come in to the department, first things first, we'll isolate you in a negative pressure room. So that means that when we open up the door to your room, air flows in towards your room. It doesn't blow out. So everything blows in, and Connie will show you some pictures and talk about how we get that set up. And then we'll send a blood test, but we don't do that blood test here. In fact, it goes to Western Washington, and it's going to take some time. I heard, I'm not sure if this is true, that it goes over on a Greyhound bus, but
they have a different system.
So, but it takes a little while. No, and so we've talked about what is Ebola, where is it at, a little bit about the outbreak, what someone with Ebola sort of looks like from a medical picture, but how do you get it? And again, maybe from bats as a reservoir, but certainly contact with meat or body fluids of an infected animal is how you're going to get it. And so you can get, so that means that if you are eating bushmeat and you have a cut on your hand, or you're skinning an animal and blood flies up, but you get it in your eyes, it gets through broken skin, you can contact it. Or if you're a nurse or a physician contacting a patient who's got diarrhea and it splashes, you can get it that way. Interestingly, the virus we can detect the virus itself in breast milk, urine, semen, and saliva. We can detect it in semen 90 days, up to 90 days after somebody's been infected with it. And so you can be cleared from Ebola. So if you have Ebola, you're treated, all supportive care, you're better, you feel fine. We do a blood test on you, the PCR test, a fancy blood test, and it's negative. We don't see it in your blood anymore. You can still have that virus in the semen. So that means that you should, and the recommendation is no intercourse for the 3 months. And so, but whether it's actually transmitted sexually is not clear. We can detect pieces of the virus's RNA, the virus's genetic material, in sweat and tears. We can't detect the virus itself, but we find parts of it in this. And that's why, it's part of the reason why we gown up so much with this, and why it's important for us to have all exposed skin as providers covered. Now, the CDC has really said you can't get this from shaking somebody's hand who has Ebola. And that's because we haven't found anybody who has been exposed to it who's had it, and we're not finding the virus itself. So, and very clearly, the quantity of the virus in the fluid you're exposed to matters a great deal. And this is not just with Ebola, this is with influenza, you name the virus or you name the bug. The more of it you're exposed to, usually the sicker you're going to be with it. And the more likely you are to get it. So respiratory is kind of interesting here. There's no direct evidence of a respiratory transmission, but there was a study done where the Ebola virus was aerosolized in small particles, and non-human primates and rodents acquired Ebola that way. So, you know, the study didn't really make clear the size of the particles, and so was this just, you know, aerosolizing coughing? Was it small particles? Were they large particles like a splash or drop? Is unclear. But I will tell you, there was a case report of a provider who was treated in Germany and got really sick with this. He required mechanical ventilation, so he had to go on a ventilator. But sometimes before we put a tube down the trachea to intubate somebody to put them on a ventilator, we'll try a step to not go that far. And if is anybody here wear like a CPAP or anything like that? So there are masks you can wear at home if you have sleep apnea. You have a similar thing called BiPAP here in the hospital, and we can use that non-invasively to try not to put you on the ventilator, right? But we don't do that. It's not recommended to do that because it aerosolizes large droplets, and there's a potential for spread with the providers with that. And so, and of note, so if you're going to eat bushmeat, you should cook it all the way and wear gloves because it's inactivated by cooking. So, treatment, always done in isolation. Like I said, it's supportive care. We try to correct the fluid loss and the electrolytes. If you're in a resource-limited area, they will actually stratify you. They'll say, you're really sick. You're not very sick. You still have Ebola, and you're tolerating fluids. We don't have a lot of IV fluids. We're going to start with oral fluids with you, and we're going to give you oral vitamins and these sorts of things. And so they do the best they can over there. Not everybody gets an IV. Treat the complications of shock. We've got lots of medicines for that here. Again, in a resource-limited area, not so much. And blood products is needed because if you do start bleeding, you may need platelets, plasma, and red blood cells. Treatment, there are no FDA-approved treatments, medications for Ebola. These two medications, these are two antivirals. This first one is already approved in Japan for the treatment of influenza. It's currently being studied in conjunction, I believe, with Doctors Without Borders on patients to see if that's effective. Brencidavir is being studied for a different cytomegalovirus as well as pox virus. It's not, again, we don't know if that works. but those are being studied. ZMapp, you might have heard of. That was the one drug that was given to the 2 patients that were first brought to the United States down to Atlanta. It was a nurse, I believe a nurse and a physician, and they both survived. Subsequently, 2 other patients have received ZMapp, and they both did not survive. This is the whole way we make ZMapp and what it does is very fascinating, beyond what I'm going to talk about tonight. But if you have an interest, I would Google the New York Times article. The New York Times has a great article on how we get this from tobacco, or harvesting it from tobacco plants. It's kind of interesting. And what it basically is an antibody. So when you're infected with something, we call that infectious agent or the entity an antigen, and so your body responds to this foreign material and you make antibodies against it, right? And so what we've developed is a way to make antibodies against Ebola antigens and give you just the antibodies, if you guys follow that. And so, refer you to that other article. And then also interesting, this has been done with other diseases, we can, along the same idea that somebody who's been infected with Ebola and survived has made antibodies against it. And so maybe if they get it again, they won't get it quite as severe or get it at all because they have some mechanism to fight it, right? And what if we took blood from a survivor and transfused a sick patient? Would those antibodies from the survivor fight the infection in the infected patient? So, and that's got conflicting data. So some people live, some people don't. There's not been any really good studies on it. It seems to make sense, right? I mean, there's all kinds of risks when you transfuse somebody because different people have different blood types, and there's all kinds of bad things can happen with that. So, prognosis, just a word here. So we mentioned the Zaire species of Ebola has the highest case fatality rate. If you have a higher viral load, so if you're exposed to more virus, you're going to be sicker. And interestingly, younger adults tend to do better. And so the case fatality rate, if you're less than 21, is 57%. If you're over 45, 94% case fatality rate. In between there was no data for that, but so that can give you an idea of a prognosis based on age. And generally, those with really severe diarrhea tend to do worse. All right, and so I'm going to turn this over to Connie right now, and she's going to talk with you about how we're prepared to deal with this.
Right now, what they're saying to us is that you need to be able to identify a patient who potentially has Ebola virus disease. We need to be able to isolate that patient and care for them for a short period of time. And we need to be able to notify the Department of Health, who is going to facilitate transfer to a higher level of care, a place where they can be assessed. So right now, the state of Washington is trying to define which hospitals will be in which roles. So the first thing is a frontline facility. And we have determined that for our facility, that is what we are going to be doing. An assessment facility is one that will be able to keep a patient and take care of them for up to 96 hours. And then a treatment facility would be able to take care of somebody for at least a month. In the state of Washington right now, we've got 7 hospitals that are working toward becoming treatment facilities. Currently, we've got 3 that are on board and ready to go. Sacred Heart is one of those, and then on the other side of the state, there's Harborview and Seattle Children's. Multi-Care will probably be coming on board pretty soon. And literally just today, they asked us to give to the Department of Health our decision on what we felt that we could do. And so we decided we could be a frontline facility. To be an assessment facility would really stretch our resources tremendously, because caring for these patients, you need 2 nurses in the room at all times around the clock, plus other folks, and it's just amazing what is required to take care of somebody. So how are we preparing? Now, we've been doing screening at the point of entry. Have any of you come in here as a patient and they ask you if you traveled somewhere else? None of you have arrived here, but we're asking if you've traveled outside the United States and to what country. Our volunteers are asking people if they come to the front desk and they say, I'm not feeling very well, you know, that's a question that they will ask. Have you traveled outside the country? And if so, they're going to have a nurse come and evaluate where that person has traveled to and then help to direct them. In all of our outpatient departments, we're asking these same questions. We've got a screening tool that we've developed for our nursing staff to use, and we'll go over that in a little bit of detail, for a patient under investigation. We've been able to get these tools placed into our electronic medical record, so that took some time as well. So if you come up to the registration desk, they're going to say, have you recently traveled outside the country in the last 30 days? And then they're going to say where, if you said yes, because a lot of people have traveled. If you've gone to Canada, we're not going to worry about it. But if a patient has had recent travel to West Africa, the countries that Dr. Lightfoot talked about, Guinea, Liberia, and Sierra Leone, then the ED, triage nurse, or the clinical coordinator is going to be notified. So this is our Ebola screening tool. I know it's kind of small for you to read, but again, it goes through the travel history, and then it goes through the symptoms. Fever over 100.4, muscle pain, chills, vomiting, diarrhea, abdominal pain, any hemorrhagic symptoms, the types of things that Dr. Lightfoot already went over. And then also, most important, have you had contact with somebody with Ebola virus disease, with their body fluids, and how long were you in contact with that patient? When did you last have your contact? Because we have to figure out, have you gone through that incubation period? Where are you in that process? And then did you handle any bats or rodents in West Africa? So these are the kinds of questions that we have if somebody has answered, yes, I have been to West Africa. So it's pretty detailed. So a lot of our planning has been done as a result of the good work of the CDC, which is Centers for Disease Control, and they have provided us with a lot of guidelines. They prepared a detailed checklist for Ebola preparedness, and so we've worked our way through that to make sure that we had things in place. We've had several meetings with a lot of the different leaders in the hospital to come up with a plan for how to take care of Ebola patients. And we've also been meeting with the county. We had one county-wide meeting, and we've also had the medical director for the Department of Health come to one of our in-house Ebola meetings as well. So that's been helpful. So we have a lot of training that we have done. We've completed quite a bit of it. We're still trying to, get a few other things done, but we've been training our employees in this enhanced PPE, that's personal protective equipment. And Dr. Lightfoot and I are going to demonstrate that for you when we're finished here. So you just have an idea of what the staff would go through to get ready to take care of an Ebola patient. We had an online module for education that we prepared and that our staff has watched. And then we've also done informal education on the units, as we're just talking with people. When we first started working on this, there was a lot of questions and there was a lot of fear involved. And so that's one of the, which was kind of promulgated by the media, I have to say, but and you probably can agree with that. But we just have to really give people the facts, and in order to help to bring that fear down, and also to assure them that they're going to be protected when they're taking care of patients. That's a really important thing. So we've had a couple of drills so far, and we do plan to have some more. Drills are good. They help you identify if you have any weak points that you need to improve. So our personal protective equipment, we have a couple of different kinds of respiratory protection that we can use, either a mask or what we call a PAPR, which is a powered air purifying respirator. It's like a hood, and it's connected to a HEPA filter. It's battery operated. We use a hood to cover the head and the neck, a face shield, an impervious gown, so something that's even a higher level type of surgical gown that you can't get any fluid or any viruses through, leg covers, boot covers, and then we use at least 2 pairs of gloves. That just shows a little bit. We had a group of our staff that we were practicing with at one time, so we got a nice group photo of them in their gear. They were having fun. We also prepared a special barrier. In our emergency department, we have a couple of rooms that are adjacent to each other. We needed to be able to prepare a barrier that would allow folks that had been in the room to come out and go to a special place to take their gear off, and so that it would separate them from the rest of the emergency department. And this is what it looks like. This is obviously not the ED, but this is our barrier that's set up. And down here is the doorway. We would go into the patient room, and then we would when they come out, then they're going to go down this corridor. They're going to go through another door here, and then actually there's into another room, and then into our area where we took our stuff off is over here. So it actually worked out well, and one of our maintenance guys built our barrier for us. And we would put tape down all these seams. But it's kind of an easy setup and take down. It's all in sections. Okay, so before we go to questions, what we'd like to do is demonstrate the putting on, and doffing, taking off of the PPE. So, okay. Observer. And that person's job is to make sure that the person that's getting dressed up is doing it properly. And even more important is when we take it off, that it's being done properly, because we do not want to have the person self-contaminate themselves, okay? So my job here is going to be to make sure that Dr. Lightfoot puts this on properly. And anyway, he could get his hair messed up. I didn't want to do that. So, okay, so the first thing always is we're going to do hand sanitizing, okay? And then, and you've got good balance, so you can probably do this. Put the we have boot and leg covers to put on. Some people would have a hard time doing this standing up, but he's got really good balance. Not everybody does, so. So these are impervious on the feet, and they are fluid resistant on the leg part. So he's going to cover up his shoes. Okay. Then the next thing is going to put this hood on, and this is to make sure that everything is covered up. We want to try to have all the skin on the neck covered up. Okay, good. All right. Okay, that's good. Okay, great. Then we have the gown, and you need somebody to help you with this, because there's, it's just got a lot of different pieces to it. And so, okay. So we would make sure that this hood is tucked down in here. The whole idea is to not have any skin showing. And there's Velcro at the top. We put it together. And here, we'll have you turn around. So then we've got ties in here, which we're going to tie up. And then we tie around here. In general, when you're using personal protective equipment, the front of you will be considered dirty and the back of you will be considered clean. So I want my tie in the back so that when we're undoing it, we're not doing something contaminated. Okay, so now we're going to put on, this is called an N95 mask. We'll do your gloves last.
Okay. Yeah, I mean, there's a lot of the same material is used in the OR, in which case you don't want to, try not to touch anything till you have your sterile gloves.
Right.
So I'm resisting the urge to I'm allowing myself to touch stuff.
Yeah, which is okay because you're not trying to stay sterile.
I don't need to be sterile, right.
Okay. Okay. So, all right. So I'm going to make sure he's got his straps on right. Okay. And then this is a face shield. Okay. There you go. So you can see everything is covered. Okay. Now we're going to do the hands, and we're going to have them just sanitize one more time. Okay. We actually use 2 pairs of gloves, and we use a regular length glove, and then we use a long glove to go over that. And we actually use duct tape with our PPE. So another good use for duct tape, guys, out there in the audience. Okay, so the regular ones. And this is a little bit different. We actually put in this case, we actually put the cuff down that way, which is different than how we usually do if you're just, in a regular isolation situation. Okay, great. Then we're going to put these gloves on. These are long. Hard to get on. Okay. Okay. All right, good. So I'm going to make sure that the sleeve is tucked in good and that this is up as far as it could go there. And then we make a little tab on our duct tape so we can get it off easy afterwards. So then we seal this up with duct tape. Okay. So, do you see any skin showing? Obviously, we can see his eyes, but everything is covered. Okay. So this is what a healthcare provider would need to do to take care of a patient that had any vomiting or diarrhea. Okay. It's not very comfortable, is it?
No, and you can imagine, I might say, well, how am I going to adequately listen to your heart and your lungs? How am I going to do a procedure on you? Something as simple as starting an IV. Yeah. So I have got 2 layers of gloves on. Some hospitals in Europe wear 3 pairs.
Yeah.
So it becomes very, in this, this is probably more comfortable, well, I wouldn't say comfortable, but less. It allows me more freedom of movement than those big inflatable ones that some of places are using. So.
Right. Okay. So this is what he's going to look like when he goes in. We actually have a special stethoscope that we've purchased that we can put some tiny little earbuds in the ear. It's electronic. It can just be placed on the patient. Well, the patient's not going to look like this. Just the.
Oh, but I mean, finding a vein on someone.
It's a very tactile skill.
Yeah, it's hard.
It's hard. Yeah.
It's right. It's hard. Sure. So it's harder. Yeah, it's harder. It is. So we probably will not be doing that here because we are not planning to keep patients for a long period of time. But we still have to make sure that our staff is adequately covered. So when he comes out, let me grab one other thing here. So before he comes out of the room, he is going to clean his hands with a disinfectant wipe. We'll just have to put stuff here on the table.
Is he getting assistance from someone in terms of taking his
Yes.
garb?
When he takes it off, he will have the same trained observer. So we have that process to make sure that he's not going to contaminate himself. And putting on can be done really quickly. Taking off can be pretty slow. So we have to be really careful about that. So he would wipe down his hands really well. If he had anything obvious on him, he would wipe those areas. He would leave that behind. But then when he goes to come out of the room, we would ask him to use a wipe to hold the door handle to do that. Then he would progress through this barrier, through this door, and into an adjoining room that is called the doffing room. And in this, you can see we've got this chart here, and we actually have one with just the steps for taking it off that we put up in that room, so that there's always somebody that can see, because this is not something you do every day, to make sure that we don't miss a step. Okay, it's all about safety, because if people that contract it, if they were wearing PPE, it's most likely that there was some kind of break in the process of taking it off, and that you somehow contaminated yourself. So I'm going to remind him, as we're taking the stuff off, I don't want you to accidentally touch your face or your eyes or anything like that. Okay? So when he comes out of the room into this special, we have a thing called a doffing pad. And so it'll be just a pad for him to stand on. And we might leave a few details out here. Actually, this is upside down, just for the sake of time, because we are running out of time for you guys. But he would step on here. Okay, so he's come out. And in general, when you come out, you usually take off the most soiled thing first. And most of the time, it's going to be gloves. As the trained observer, I would also be garbed up. I would not have an N95 mask on, but I would have the gown and the gloves and a face shield and a simple mask for sure. And depending on the situation, if he was coming out and I knew he was a mess, I'd probably put everything on too, just to protect me. So the first thing is we're going to take off these gloves. So if he wants me to, I can help him do that. You just got to be careful, you know, how he does it, and that'll be our garbage can. Yeah. No, we don't need to save it. We won't reuse it. So you have to just be really careful on doing that. Okay. And then the first thing he's going to do is take one set of gloves off. And remember, you want to kind of go down a little bit further on the first one. So see, we're here to kind of remind ourselves, you know, just great, perfect. All right, perfect. You can go ahead and get another one. Perfect. And he's taking these off slowly. He's not flipping things around, and then those would go in the garbage can. Okay, great. So he's got the first ones off. Now I'm going to help him take the gown off. So we're going to undo him here. This is going to go like that. I'm going to undo this. One. Okay. Then I'm going to do that like that. And then he is going to take this off, trying not to. Very good. Good job. He's keeping it away from his body. He's turning it in, and then he's going to roll it up, trying to not touch the outside of it at all. Okay, so we'd all get rolled up in a ball and then put aside. Okay, great. Now, if he was going to take off his own shoe covers, I would have him clean his hands again, just so that he's not, in case he potentially touched anything. But often the the trained observer will help them do that. So I think, why don't you do one and I'll do the other, and we'll just show people how that would be. So if you do one, he's going to go inside and he's going to roll it down. And again, he has very good balance. I probably could not do that. If I were the trained observer doing this, then I would reach in there again and rolling it down. We're going to take that off. Okay. Because some people might have a hard time doing it themselves. Okay.
So I wouldn't do that if I, you know, if I was really doing this, I wouldn't risk it.
Yeah.
Take it off nice and slow.
Okay. So then he's going to take off this pair of gloves. So carefully. And then he's going to go underneath there. Okay, and that's going to get discarded. Okay. And then,
explain it just like you were doing.
okay. So he's sanitizing his hands. And then I'm going to offer him some more gloves. Okay. Because you want to have clean gloves on before you do anything around your face. Okay. So now he's going to go ahead and take the face shield off. And we always go from the back forward. We consider the front dirty and the back clean. Discard that. And then you're going to go ahead and you just want to grab your, okay, grab that and pull both of them off. Great. And discard that. Then you'll remove those gloves. And sanitize the hands again. And then before he leaves, I'm going to take a disinfectant and I will clean the bottom of his shoes before he steps off. Okay. And then he would go, yeah, and then he would go and take a shower and change his clothes. And then go back to work.
Right, and so if a person comes into the emergency department, and so if I see a person, I can't see other patients
right.
in the emergency department while we're doing this, and so another provider, another physician is going to have to come in and take over care for the existing emergency department patients and for the new people who are checking in. As you can see, this is very time consuming, and we want to do it right. And reduce, exposure to other patients too.
And it usually takes about 20 minutes to take the gear off. Yeah, 15 or 20 minutes to take. Getting dressed is pretty quick, but taking it off, it takes quite a bit of time. So we kind of rush through it here, but anyway.